Hello, everyone. Welcome. We're so glad you're able to join us today. I'm Alisa. I'm our policy director here at the Arthritis Foundation. I'm joined by my colleagues, Anna Hyde and Stephen Schultz, and we are going to share with you a little about our Platinum Ambassador legislative asks for the 2022 session this year. Remember, we're here to help you. We are really trying to arm you with some information that you can take to your meetings with your members of Congress, and we're always here to help talk through any questions or best talking points, make sure that you feel comfortable telling your story. And so we're going to walk through what our legislative asks for, what they are this year, how we arrived at them, some inside scoop details, and then we will follow up via email and through the app with additional information, data points, and talking points for you to take with you. So make sure if you're watching this video for the first time, you have a pen and paper handy or your computer, and we will provide those materials to you to back yourselves up for the meetings. I will pass it over to Anna Hyde. She's going to tell us a little more about the overview of our legislative asks this year.
Yeah, hi everyone. I think you are probably already familiar with these asks, at least a couple of them. We're going to do a little bit of overview of the asks just in case, but we're really going to spend the most of our time on the state of play and what our goals are for this year to give you that sort of inside scoop that Alisa was talking about. So let's just start with, how do we arrive at our legislative asks? Well, we really thought about what are our core priorities for this Congress, the 117th Congress, and where we landed was on pocketbook issues, the things that impact our patients the most. And, you know, when we say pocketbook issues, we're talking about out-of-pocket costs, but we're also talking about the administrative burden that goes along with managing your health coverage. So our top three priorities for this year, and that we're going to be talking about on the Hill, are step therapy reform, out-of-pocket caps on Part D for those of you on Medicare or approaching Medicare, and accumulator adjustment programs. That's the doozy that you may or may not be familiar with, but we'll get into it. It basically just has to do with whether copay assistance that you may use for your drugs can count towards your out-of-pocket costs. So because we have three issues that we're dealing with, they all have completely different states of play on the Hill right now. So what we're going to do, it's a little different than normal, but because this is our Platinum Ambassador group, we feel really comfortable doing this with you all. We're going to roll all three asks into one. So we'll have one pager that lays out the broad narrative of why these pocketbook issues are so important to patients being able to access their medications. And then from there, we'll set out a set of solutions and basically put a menu of options that members of Congress can do. So you'll be able to use the same one pager for any meeting that you're in. And it'll basically say, if you are not already a co-sponsor of this bill, make sure that you are. If you are a senator, consider introducing this bill, and so forth and so on. So with that, I'm going to turn it back over to Alisa in just a second. We'll just give you just a couple, like one or two little housekeeping notes, which is, as we go through these, we'll give you bill numbers and committees of jurisdiction. What you might want to do is, as we go, make sure you write down the bill numbers, and you can go onto congress.gov to see if your member of Congress is already a co-sponsor. That's going to be really important information to have in your meetings. And then see if they're a member of any of these committees of jurisdiction, because that will also be really important. It will give them more power over the bill than someone who's not on the committee. So with that, Alisa, I'm going to tee you up for the first ask, step therapy, because you just became the co-chair of the major coalition that we are part of, the Safe Step Act coalition. So you have all the inside baseball into what's going on with this bill right now.
It's true. It's true. Thank you. I assumed that role about a month or so ago, but have served on the steering committee for the Arthritis Foundation since I joined the organization. So it's been fun getting to help steer some of the direction. So you all are aware of step therapy. You've worked on this issue for years in different capacities at the state and the federal level. We have been talking more in coalition as part of our team about reforming some of the messaging. How do we bring this topic of step therapy to be a highlight for members of Congress, to say that this needs to move more urgently, that it is a bigger issue, and how do we get bipartisan support to move things along successfully in Congress? You know, they have a host of other topics that they're talking about in the world, especially this spring. And so we want to prioritize step therapy for them. And I think one way that we've discussed doing this is to focus on the bigger umbrella term, which is called utilization management. You might be familiar with this already, so we're just going to level set really briefly. Utilization management, or you could just call it the letters, would include step therapy and prior authorization. They are broadly a set of techniques that private and public health insurance plans use as a cost containment strategy. It originated out of this concept of, increasing costs of healthcare, increasing demand for high quality of healthcare, and how do we tamper the higher costs collectively felt by the healthcare system, not just by patients. And so insurance companies were looking at whether a treatment or a service is medically necessary. Is it appropriate? How do we improve efficiency in healthcare? By influencing the patient decision-making process and doing so on a case-by-case basis. So every time would be different. So initially it looked at a lot of hospital utilization management starting in the 60s, the 1960s. Hardly anybody really experienced step therapy. Prior auth wasn't really in the picture at the time. It kind of gained power or use. People started increasingly using it in their health insurance plans through the 80s. And by the 1990s, the mid 90s or so, over 90% of privately insured employees, as well as all of Medicaid and Medicare participants, had utilization management insurance plans. It really came from a system that focused on fee-for-service plans, and not a lot has changed since then. But all that to say, the goal of was to save money, to improve the quality of care, and to lower the cost compared to savings. So lower your expenses, increase the quality. So commonalities across the board, this big umbrella term, we are going to focus on step therapy. We just want to provide you with this line, this word that you can use so you know that it all falls into a broader category. But I really think that when you're talking about it, you don't need to worry. You can really just say, this is part of a bigger picture called and this is my step therapy story, which is an example of But for those of you who might be new or may have focused more at the state level and less on the federal level, the Federal Safe Step Act has a Senate and a House companion bill. So there's one in both chambers. They are identical pieces of language, and they are actually modeled after the state bills that we helped to create and have passed in many states. And Stephen will talk a little more about that. But it really does make some common sense guardrails. It does three main things, which you're probably familiar with again. It streamlines step therapy for patients with employer-sponsored insurance. It does not work on Medicare. It does not work on Medicaid. Those are separate issues. This is just for ERISA plans or employer-sponsored plans. The first is it establishes an exemptions process for review by health insurance plans. It creates a time frame that they have to respond and make sure that we're leading with transparency and clear, reasonable expectations, as well as requires the insurers to consider the patient's medical history in that decision. We really like this because it puts the impetus back into the hands of the patient and provider. It helps to promote that relationship over a health insurance company's plan, which may or may not be clinically backed. It may or may not have evidence for that decision. And so we really want to put the goal for patients to be able to get the care that they need in a timely manner.
This bill has been around for a bit, and we have been growing support for it for the last 3 Congresses now. So where are we right now? What can our folks expect, and what have the Hill meetings that you've been part of looked like so far?
Yeah, so I think there is actually a lot of positive momentum recently. As part of the steering committee, the staff representing a lot of our patient and provider organizations have been meeting with committee members of jurisdiction, especially with the Education and Labor Committee. We have collectively met with all of those members, all of the Republicans, all of the Democrats on the House Education and Labor Committee. And it seems to be pretty much there's a good interest in having a hearing on collectively. I don't think that we're going to see a standalone bill move on any of these topics. The Hill is really focused on a variety of other healthcare issues. And I think that there is potential for us to work in collaboration with other subjects that fall into that bigger umbrella topic of So with that said, our goal is still to encourage members to sign on as co-sponsors. You can always ask your member to sign on. We have 108 co-sponsors in the House. We have over 30 co-sponsors in the Senate, which is amazing given that in the 116th Congress, we had 18 members in the Senate, and now we have 30, and we're not even the end of the year. We have some movement in the House that we could work on. We have 108, as I said. Our goal is 220. That's kind of a goal that our team has set. We obviously want more, as many as we can have. Last time there were 157, so we said let's just go ahead and aim bigger, so we added a handful more. The goal is still to maintain bipartisanship. We have a really strong presence from all members in both chambers, from both political parties, and that's definitely a goal to maintain. But with that said, the more the merrier. So ask your member to sign on, encourage them to ask, if they are a member of a committee of jurisdiction, to go ahead and ask for a hearing for the bill and to mark up the bill. And then we as staff are also looking at other vehicles that we might be able to include the language in an omnibus package, for example, or other areas that we might be able to create some forward movement for the legislation. So those are our big ones. But it does seem that there is an appetite for it. So that's really encouraging. And I don't think that we've had that in the last handful of years, the last 2 years especially, because all focus was on the coronavirus and everything was kind of put on hold, I think is a fair way to put it. And so now we're seeing a reemergence of the appetite to have conversations about these other pieces of healthcare legislation, which is exciting.
Well, I know that in some of the meetings I've been on this bill, one of the things that comes up often is, Hill staff pretty broadly know now that there's been a lot of momentum at the state level, that a lot of states, we kind of reached that tipping point a few years ago with more than half of states passing some form of step therapy reform. And so they want to know what's going on in my state. Has my state passed this law? And if so, how is that working? Is it driving up premiums? Is it not? Is it benefiting the people it's intending to benefit? That sort of thing. And so the more information that we have about what's going on back home, the better. So it just so happens we have Stephen Schultz, who runs our state program, here with us today. And because he sits on the big coalition that is prioritizing step therapy at the state level and is just coming off of his first lobby day of the year on this very issue in Tennessee, I'm going to ask him, what is the state of play at the state level and why does it matter to the federal bill?
Yeah, I think something that we haven't touched upon yet is that you may be asking, like, oh, well, we run all these state bills and we have a federal bill. Why do we have both? Why don't we just put our eggs in the federal basket? And it's because of kind of how our insurance is regulated in the United States, where we have kind of some plans that you may have that are federally regulated and some that are state regulated. So to kind of have some of these patient protections or work on some of these things, we're going to have to pass it in kind of all 50 states and get federal legislation enacted. And so that's why you're going to see kind of this activity on both levels and how they can add some of the synergy or momentum with each other. I think I like to say is that like what Anna said was that we had this rush in the last decade of legislation and enactments on step therapy reform, and that ultimately had led to legislation of the Safe Step Act getting introduced. And I think we've seen some great successes as far as the federal legislation of legislators looking at what happened in my state on this issue, or seeing state legislators reach out to their federal legislators and say, hey, and talk about the importance of these protections that are, like Alisa said, the same protections, almost the same exact bill. And so we've seen 20 plus states enact some form of step therapy legislation. We're almost now into the state of play of not only looking at new states and getting this enacted in new states, but there's now a lot of these states that may have enacted a very early version of this bill and may not have gotten any kind of exactly where they wanted to. They may have been able to get some of the exceptions, but not all of them. One other thing that I want to just mention is that I think Alisa hit on it, and it's true in the states too, is that these bills are very bipartisan nature, and can pass anywhere. This is something that we've been able to pass in southern states, but in New England states, out west, and in the Midwest. And so this is something that we've seen. Those 20 states aren't just one segment or one party. This is something that we've seen a lot of bipartisan nature, and that's kind of goes along with federal as well. And then the last thing I'll say is the importance of implementation. That's something that we'll stress throughout kind of this. We're kind of even having a session dedicated to the life cycle of the bill, and hitting on that implementation factor of kind of after the bill passes, what happens? What's the education that's necessary? How do we educate? How do we make sure that the doctors who are designed to be able to apply for the exception for step therapy and track it in their office are making sure that they know about these rules, and that they're being followed, and what they do if they're not being followed correctly.
Yeah, those are all very good points. Thank you, Stephen. And again, that's the Safe Step Act is HR 2163 in the House and S 464 in the Senate. It's Ed and Labor is the Committee of Jurisdiction in the House, and the Help Committee on the Senate. So let's shift gears to our second priority, which is Part D cap. Some of you have been really intimately involved with us on this issue for the last few years. It's one of my personal top priorities. You know, so many of you have either experienced this or you know someone who has experienced this. You transition from a commercial plan to Medicare, and you all of a sudden realize that you can no longer use copay assistance. It is illegal in Medicare to do so. So you may have been relying on copay assistance to afford your medications, and then all of a sudden you realize that you can't do that anymore. And you not only have to pay the full copay or coinsurance or whatever it may be for your Medicare Part D drug. Part D are the self-administered or what you get over the pharmacy counter as opposed to physician-administered drugs. But there's also no cap on out-of-pocket costs in Medicare. That's something that a lot of folks aren't aware of. But when the Affordable Care Act passed in 2010, it included out-of-pocket caps for commercial insurance and for exchange plans, but not Medicare. So what we are trying to do is to cap out-of-pocket costs in Medicare Part D, and to allow patients to be able to spread those costs over the plan year, because a cap only takes you so far. Let's say the cap is even $2,000. Many people do not have $2,000 lying around that they can pay in January, which unfortunately is what we see often with the higher cost medications. This is true for a lot of arthritis patients. It's true for a lot of cancer patients, MS patients, other patient groups we work with experience this too within their populations, is that you're hitting those high in the Medicare program. Often it's that catastrophic phase, or if it's in the commercial market, you're hitting your out-of-pocket maximum in the first quarter of the plan year. So the ability to, we're calling it a smoothing mechanism, to be able to pay that over the course of the plan year really can make a huge difference for folks. This is driven by patient stories that we've gotten that are really devastating, and we want to be able to do something to help folks. But it's also driven by surveys that we've done showing the amount of people who have been impacted by this, what we would consider kind of a loophole. So this is one of those really interesting issues that doesn't really have a clean bill. Like the Safe Step Act has a House bill and a carbon copy Senate companion. This issue has none of that. So the good news is that the Part D cap issue is extremely popular among the patient community, the provider community, and on the Hill. It's bipartisan. It is popular among congressional leadership in both the House and the Senate. So you might be asking, why isn't this done then? Why isn't this a slam dunk? Well, the answer is that it's really political. And we're not going to get into that with our asks. We're really going to focus on the human face of this and why it's important, and asking members of Congress to remember the patient. But just for background, the House and the Senate have both really prioritized drug pricing reform this Congress, and the House Democrats and the House Republicans have both put out their own versions of drug pricing legislation. Both of those bills include reforms to the Part D program, which is great. The problem is that the issue of drug pricing is inherently controversial and political, and therefore this, what we would consider bipartisan, broadly supported policy, is getting caught up in that. So our goal is to really separate the politics from the policy. It's what we've been doing as staff, and it's what we're asking you to do as advocates, to remind members of Congress that behind all the dollars and cents, there are people who are being impacted. And right now they're being impacted by the inaction of Congress. So you might have heard or seen a lot of our newsletters in the fall. This was very much a part of the big Build Back Better vehicle that we thought was going to pass in September and still has not passed, and it's unclear whether that is going to go forward or not. So we are really open to other vehicles by which we may move this legislation. We're putting a lot of pressure on congressional leadership, and in fact, we are going to join a number of patient organizations this week, this week being the week of March 7th, for whenever you may be watching this video, to urge congressional leadership, both House and Senate, to prioritize this issue. And so we'll be giving you a copy of that letter, and you can use it in your outreach as well. The timing is really great for you all going up to the Hill right on the heels of that effort. So that's the state of play at the moment. Alisa, did I miss anything there? You've been working on this issue as well. Any talking points or nuggets that you would put out there?
Yeah, I mean, I think it's important to remember that, like Anna said, there are many vehicles. There have been many different versions and dollar signs and limits. Don't get caught up in all of that. It's a lot of negotiation behind the scenes happen. So I don't want you to worry about what specifically the dollar value is or what exactly the number is that we're asking for. We want to have our advocates get back in front of the legislators and remind them, like Anna said, of the human face and the impact of your patient stories. That's the most important part. And I think on the Hill, correct me if I'm wrong, Anna, but there are a lot of voices on drug pricing. Sometimes the patient voice gets forgotten about or lost in the process of everybody else and their big hitters. So our goal really is just to remind them that we're paying attention, we're here, this is important to us, and tell your personal story if you have one about it.
Yeah, the personal story is really key here. It's what members of Congress really want to hear. And so just to kind of distill this down, the ask is support a Part D cap with that smoothing mechanism that we talked about. That's the ask. The vehicle we're completely open to, and you don't need to worry, to Alisa's point, about what that might look like. That's a good follow-up opportunity for us as staff to go back in and talk more about that. The committees of jurisdiction on this particular issue, though, might be important to know. On the Senate side is the Senate Finance Committee that has jurisdiction over this issue. And on the House side, there are two committees that we are working on, the House Ways and Means Committee and the House Energy and Commerce Committee. Okay, so our third and final ask is that accumulator adjustment program phrase that I used. You don't really need to worry about that phrase. You don't really need to use it yourself if you don't want to. Really what we're focused on is copay assistance. We have already talked about that and how much of a lifeline it is for many patients to be able to afford their medication, especially if you pay a co-insurance, which could be 20, 30, even 40% of usually the list price of a drug. So that adds up to a lot of money when you're looking at expensive biologic medications, for example. So what we have been focused on for the last few years is kind of an emerging practice that we're seeing among payers and pharmacy benefit managers, where to steer patients away from using copay assistance or to use medications that are generic, for example, and not brand name drugs, they are putting in place policies in which your copay assistance cannot be counted towards your out-of-pocket costs. So your deductible or your maximum out-of-pocket. Okay, so that's really all that you need to know for this particular issue. Why that matters, there are a few reasons, and there's a few different angles you can take with this. If you've experienced this yourself, this is another great place for the patient story. But oftentimes you're not aware that your health plan has this policy in place. And perhaps you've been going along for the past 10, 15 years or however long it is, using your copay assistance, and then you reach the end of the assistance, but it's counted towards your deductible. So you're not whacked with this huge, perhaps multi-$1,000 charge the next time you go pick up your prescription. Well, now all of a sudden this plan is put in place, this program, and you go to the pharmacy counter to get your drug, not realizing that all this time that copay assistance is not accumulated towards your deductible. And now you are on the hook for however much that is. In surveys that we've done, we've seen sort of what the impact can be when this happens to you, and none of it is good. So sometimes you're abandoning your therapy because you don't have the money to purchase your prescription, or you're delaying the fill, or you're calling your doctor and asking to be switched to another drug that you can get copay assistance for. None of those are things that we want you to have to do. And so we have taken a real leadership position within the patient community in the past few years around this issue. And there is a state of play at the federal and the state level, but really more so right now with the state level. So I'm going to turn it back over to Stephen to talk about what's going on there, because that's where we've really seen legislative success so far. And then we can get into where we are federally after that. So Stephen.
Yeah, I think you're right in saying that when you think about accumulator adjustment programs, it's not like it doesn't translate well to kind of what we're trying to do. And so you'll see kind of in a lot of our communications about this, our coalition nationally is called All Copays Count, because that's what we're just trying to do. We're just trying to make sure that no matter who's paying it, whether it's the patient, a third party, that any copay should count. And so you'll see that kind of hashtag used, that dialogue around the issue used for that exact reason, is that cumulative adjustment program is not the greatest term, but I think you're right. The state of play has definitely been in the states so far, and similar to step therapy, I think a lot of the momentum around these bills on the state levels led to this discussion taking place on the federal level, and I think in turn that this discussion on the federal level is going to help the states. But I think we've had 12 states that have enacted accumulator adjustment program bills, and they're usually the shortest bills you're ever going to read. It's just ensuring that, hey, whether it's funds paid by or on behalf of the patient, should be counting to the patient's cost sharing. And then I think kind of the state momentum with this is that we have, like I mentioned, 12 states that have enacted bills, 7 last year, 18 states active or that will be active this year. And so you're seeing this momentum that's taken place. Unlike STEP, where a lot of that momentum has taken place over a decade, this has taken place really in just a couple of years. And because of that, I think you're seeing a lot more knowledgeable legislators, advocates, their staff, because of that. Whereas if you're doing something over a decade, you're going to have legislators come in and out. You're going to have staff come in and out. Whereas this is all taking place really within this session. So you're having very knowledgeable legislators. So even if it's a state that hasn't enacted legislation yet, when they're coming back this year to work on it, they're becoming a little bit more knowledgeable about this, or they've heard it from somewhere because of all of this momentum taking place around it. And so I think that's where that will only continue to grow, since this is an extremely new issue. This is something that's really, really brand new on the scene, and so that's only going to help with momentum and being able to find stories. And if you have stories, that's really going to help build that momentum and ensure that we're able to combat these types of restrictions on assistance. And then the last thing I'll say is that, very similar to step therapy, very bipartisan nature in something that can pass anywhere. This is something that we've had a number of states in the South pass it, but we've also passed it in Connecticut, in Illinois. It's hopefully soon to be passed both chambers in Washington, head to the governor. So it's something that you're unlikely to find kind of one party or in nature not be bipartisan. So that's what we're excited about. It's another one of those types of issues that is no matter who you're talking to, they can usually get behind it. And then Anna, yeah, if you wanted to touch more about what the state of play is federally, that'd be great.
Yeah, so one thing that we've learned from the state side, and this is not just true for accumulators, but because we've had so much success at the state level with accumulators, it's put a fine point on it recently, is that the state bills will only take you so far, and there are certain components to this issue in particular that really have to be addressed federally, loopholes that have to be closed, for example, and one of them that we're working towards at the federal level is when the Affordable Care Act passed, it allows employers or employer-based health plans to deem certain categories of prescription drugs as non-essential, even when they are life-saving or necessary. So you've probably heard of the essential health benefits, and prescription drugs are a category of that. But employers aren't obliged or required to cover those necessarily. So one thing that this legislation that we're working on, and we'll talk about in a second, does is it closes the loophole that allows health plans to take those drugs off of the essential list and put them in the non-essential list, which essentially forces patients to enroll in a special or specific program that plans are increasingly using, where they're able to take the copay assistance for the medication on the back end. And you as the patient aren't necessarily impacted by that, but it still kind of puts you in this place where you're all of a sudden in a plan in which your drug is considered non-essential. So that's a loophole that we want to close, and we have been working with the coalition that Stephen mentioned and some champions on the Hill. So again, that bipartisan nature is so important. So we have 2 bill sponsors, one Republican, Rodney Davis from Illinois, and one Democrat, Congressman McEachin from Virginia, who are leading this effort. This legislation is very new. It was just introduced in the late fall. And so we are kind of at the beginning. We only have 17 co-sponsors at the moment and really need to build that. I will tell you that from our meetings on the Hill and what we're hearing from other patient advocates who are also doing Hill days on this bill, what they're hearing is that a lot of members of Congress just don't know about the issue. Like Stephen said, it's relatively new. It seems a little obscure. It's really not when you think about it. Copay assistance and out-of-pocket costs are things that many of us have to deal with at some point in time. But it just the way in which this issue is playing out, it maybe feels a little new or different or obscure or unknown to people. So there's an education component. That's certainly one of our goals in our Hill meetings, is to educate members of Congress about it, why it's a major issue. If you have been impacted by it, definitely tell your story. But even if you haven't, this is a good place to use a hypothetical. What if this did happen to you? What if you did go to the pharmacy counter and all of a sudden we're told that you owe this exorbitant amount of money that you weren't prepared for? How would that impact you? What would you do? And then the other goal is to build the co-sponsor list. We've already talked about why that's so important. It shows congressional leadership and that committee of jurisdiction that a groundswell of support is behind this bill. It spurs them to give it that hearing or the markup, which is necessary for moving it forward. So we want to build the co-sponsor list. We want to raise awareness about the issue, and we want to get a Senate companion because that's something that we don't have yet. So as you're having meetings with your senators, just really sort of make the case and encourage them to consider being the champion on the Senate side and introducing the bill. So that will all be covered in the materials that we send you. But basically, this bill, which is called the Help Copays Act, it will close that loophole, and it will make sure that that copay assistance does count towards your out-of-pocket costs. Those are the 2 main things that we're trying to preserve here. I will say, just as another bit of context, that we have been working with the administration, actually the past 2 administrations, to have this taken care of through rulemaking as opposed to legislation. But we have not gotten the commitment or the support from either administration to date. We're still trying. We're still working on the administration. We've been doing a lot of awareness raising on our own over the last few years, but because we haven't seen that commitment from on the regulatory side, we feel that the legislation is that much more important. We're really putting all of our eggs in this basket at this point, at least for this year, 2022. So that makes the bill and our advocacy on the bill even more important. There are a number of patient groups who are going to the Hill on this issue as well. Some already have, and then obviously we are going to the Hill on this, and then others will throughout the spring as well. So we're really looking at this as a collective effort and hoping that we can each build momentum from each other and raise that co-sponsor list. So I will stop there and just say that the bill number is HR 5801, and the committee of jurisdiction on this one is Energy and Commerce. So that's, I think, the core information that we wanted to make sure that you have. I'm going to turn it back over to Alisa to close us out and give any parting thoughts.
Yeah, so you've heard our 3 legislative asks. Remember, all of them seem like they're a little bit different, but they're actually all connected. They all have to do with your pocketbook, your out-of-pocket cost issues, and the best way to protect you as a patient. Main takeaway, tell your story. The legislators really just want to hear from you. They love hearing from staff, and we can get into the nerdy, specific details and what the legislative language really looks like in comparison documents. But your task is really to tell them how it's affected you. If you want to pick one of these topics or all three of them, that's great. The other main thing I want to remind you is that all of these topics, legislative asks, are all bipartisan this session. We really want to emphasize the urgency in passing these reforms. We want to maintain positivity. There seems to be good momentum on the Hill, and so I think bringing our patient voice back into the picture is really important. And lastly, make sure that you look up your specific members of Congress, their health staff, know who they're, if they sit on a committee of jurisdiction or not, and if so, be sure to ask them to go ahead and take that next step, not only in becoming a co-sponsor if there is a bill like the Safe Step Act or the accumulators bill, but to encourage them to have a hearing and mark up on those pieces of legislation as well, or to find a vehicle for any or all of these topics that are important. Those are our main takeaways. Be sure to check out all of the materials we'll send you. Again, we'll give you talking points. We'll give you data. We're going heavy on the data points this year, I think. In particular, we want to make sure that you're armed with evidence to back up the things that you're asking for, and to do so in a positive way. So be sure to reach out to any of us. The whole team is here and happy to help answer any of your questions. Again, you can feel free to email or send a message to Stephanie or to Sydney. Any of us would be happy to talk through any of the legislative asks with you further. And we're excited to see your success on the Hill. Be sure to check out the other videos, read the materials, and we will see you at our official kickoff. Take care, everyone.
Thanks, everybody.